Hello, welcome to the University of Washington Cardiometabolic Echo. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. And today we're really excited to have Nayan Arora, an adult nephrologist, and Kelley Branch, an adult cardiologist, duking it out about the renal versus cardiac benefits for our sodium glucose cotransporter inhibitors. And today we also have Lorena Wright, an adult endocrinologist, to also weigh in about the glycemic benefits of these medications. And then finally, we have Allison Ward, our mental health specialist and psychologist, who will be helping us with the case today. So without further ado, Kelley, go ahead and start this great session.
We're going to talk about SGLT2 inhibitors, and we'll talk about two different parts of it, one of which will be more cardiovascular, then we'll talk about nephrologic issues. But really, it comes down to cardiorenal and that intersection between the two, because one of the suggestions that have been made is that with these new diabetic drug options, i.e. SGLT2 inhibitors or GLP-1s, these really happen to be cardiovascular medications, which just happen to help people that are living with diabetes. So let's talk a little bit about the SGLT2 inhibitors today. And our objectives is that we're going to describe the SGLT2 inhibitors for diabetes in terms of mechanism of action, some of the efficacy, as well as some of the side effects, but really going into some of the cardiovascular as well as the renal benefits, and as well as a little bit talking about liver and NASH. It's important to understand that, of course, yes, these medications have benefits, but what's the side effect profile? And then really what's the risk and what are some of the data? Because I think some of the risks have been overblown a little bit. And so we're going to try to bring that into context. And then finally, how do we translate this into our patients with renal disease, with heart failure, as well as cardiovascular disease? Here are the disclosures. None of these are all that pertinent, other than I have worked with a number of individuals that, I should say pharma, that do mostly GLP-1s, as I've said. Dr. Arora has no disclosures. So thinking about some of the cardiovascular complications, it really is found within individuals that are living with diabetes. And then if you look at both either the heart or peripheral arterial disease or stroke, you can see that there are these microvascular complications, of course, but the macrovascular complications are really remarkable. And that is that 2/3 of the deaths attributable to those with type 2 diabetes are attributable to cardiovascular disease, and mortality is 2 to 6 times higher. This is a big deal. But I think what's also important and really salient is that the higher risk of developing congestive heart failure is about 2.5 times in those individuals that are living with diabetes. In addition, stroke is very common, or cerebrovascular disease. And for every 1% increase in the hemoglobin A1C, we see that stroke has increased by about 30%. In addition, those patients with peripheral arterial disease, those are the highest risk cardiovascular patients that we have, patients with peripheral arterial disease or in multiple beds. Those patients have peripheral arterial disease. It's underdiagnosed, but when present, this increases the risk of heart attack and stroke more than anything else that we have. So I think most of us know that the SGLT2s, there are multiple that are out there. They're really the big three of canagliflozin or Invokana, DAPA, and then EMPA, because there's Farxiga and Jardiance here, and then the new kid, ertugliflozin, Delagritro. I haven't even quite gotten to that one yet. Then we have a number that are coming out, including one that has gotten a lot of press with Soto. This is actually a shared space of SGLT2 as well as SGLT1 inhibitor, and we'll talk about that just in a little bit. What are some of the physiologic actions? If we look at what the SGLT2 inhibitors do, they selectively block the SGLT2 transporter. And I'm not going to go too deeply into this, but essentially what it does is by blocking the SGLT2 transporter, you basically become glycosuric as well as decreased sodium absorption. And so because of this, we get glycosuria as well as some natriuresis. And so because of this, we actually decrease hyperglycemia, but then you're also basically excreting glucose-filled urine. And this has actually been shown to be beneficial in multiple different ways, one of which is that the risk of hypoglycemia, which I think all of us are really quite intimidated about, is actually substantially lower and actually is very difficult to happen with SGLT2s as opposed to the other agents because the action is independent of insulin. If we look at the mechanisms for cardioprotection, there are really multiple different ways. One of which is by decreasing volume. We both decrease preload as well as afterload, and that's manifested in preload. These are actually reversed. Preload, which is decreasing the central venous pressure, and afterload by decreasing systemic hypertension. And then through other ways, we're actually decreasing some of the inflammatory and pro-inflammatory cytokines. So it's actually an anti-inflammatory medication as well. This manifests in a couple different ways to decrease cardiac fibrosis, and then actually increases hematocrit as well as erythropoietin, and it really increases cardiac metabolic efficiency. It's a very interesting mechanism. We're not going to be able to go into it, but just know that those are there. And then Dr. Arora is going to talk a lot about the mechanisms for renal protection, so I'll go ahead and skip those for now. Notice it's a complicated slide, and it's only really meant to illustrate that there's really a lot going on for the benefits of the SGLT2 inhibitors. You can see all of these different things, but really what it comes down to is that we manifest by improving some of those loading conditions we talked about, both preload and afterload. We actually get a little bit of weight loss along with this, even though the GLP-1s are mostly what we talk about when we're talking about weight loss, as well as an increase in hematocrit, and those can be beneficial for our patients, and especially in patients with heart failure, you can imagine that these would be quite beneficial. There's a lot of novel mechanisms that actually go into this. Again, this can be reviewed. This is a nice review from Joshi in Hearts in 2021, which actually goes through all of these very interesting mechanisms. But really what it comes down to is that it manifests and improves cardiovascular outcomes in multiple different ways. And if we actually look at the inhibitor trials, you can see that it's relatively recent. We've got the EMPA-REG in 2015, which was supposed to be a phase 2 trial, but actually ended up showing such benefit that everyone got very excited because we actually had cardiovascular outcome benefit. Then you can see many other data as it comes about. I'll talk very briefly about this, and that is that there could be an additive benefit by actually having an SGLT1 inhibitor. And that is that SGLT1 actually is something that absorbs glucose in the small intestine. It contributes to the reabsorption of nephrotic glucose. And then if you have, I should say, basically all the SGLT2s are selective. And there's always a little bit of SGLT1 antagonism. And you can see the relative amounts here. And it's really the SOTO down at the bottom. That's the new one that is currently being tested and actually has some cardiovascular benefit. So there may be something to actually adding not only SGLT2, but also SGLT1 inhibition. If we look at some of the outcomes trials, most of these are just more gestalt, but just so you know where these data are coming from, that if you looked at some of the large phase 3 trials with EMPA, canagliflozin, and dapagliflozin, you can see here that overall for major adverse cardiovascular events, also known as MACE, and this is generally MI, cardiovascular death and stroke, you can see that overall the hazard ratios were in the right direction. When the meta-analysis was done for atherosclerotic disease, we saw a substantial benefit. Interesting, in those patients with multiple risk factors but without atherosclerotic cardiovascular disease, we didn't actually see the same degree of benefit, although we do see confidence intervals. So it really does favor those that are in the secondary prevention, atherosclerotic cardiovascular disease. When we break these apart, some interesting things we're seeing. Number one is that we saw more benefit in myocardial infarction as well as cardiovascular disease, but interestingly, stroke actually didn't have much benefit, even though we think that it should, but really with the meta-analysis for the big 3 trials, we didn't see much benefit. So in this case, when we're thinking about these patients, thinking about reductions in MI or cardiovascular death, yes. For stroke, if that's your primary outcome that you want to prevent, GLP-1s may be the way to go. What was really more beneficial than anything else is the hospitalization for heart failure. And hospitalization for heart failure and manifestations of heart failure has been substantially reduced with SGLT2s, and this is the real power. And we saw this very significantly with patients with atherosclerotic disease, patients with multiple risk factors. We saw a trend in the right direction. If we were then to look at patients with existing heart failure and whether or not it's preserved or reduced ejection fraction, it didn't matter all that much, although most of the data were with reduced ejection fraction. If we look at all-cause mortality, there was really only one, and that was DAPA, that showed that there was all-cause mortality. But when pooled together, overall, we see that there's a substantial reduction in mortality, so it actually saves lives. If we looked at heart failure hospitalization, multiple of these showed benefits, and again, pooled together, about a 32% risk reduction in heart failure hospitalization. This is a huge benefit and this is on top of what we do already in using beneficial cardiovascular disease for heart failure. If we then look for patients that have diabetes or patients that do not have diabetes, you can see that the benefit really doesn't matter all that much. And that's why we say this is a cardiovascular medication that happens to be masquerading as a diabetic medication, but really substantial improvements in heart failure hospitalization. And then when you look at cardiovascular death in patients that are living with diabetes, there seems to be a little bit more benefit than those who are not currently having diabetes. But overall, again, in those patients with heart failure, much benefit. And if we looked at the subtypes of heart failure, whether or not we had preserved ejection fraction, that's generally ejection fractions that are over 40%. There's kind of that middle ground between 55 and 40 versus those with reduced ejection fractions, less than 40%. HFpEF, we saw there were some data that we may see some benefit. Pooled data analysis was not all that impressive. But in patients with reduced ejection fraction, as far as mortality goes, we saw a trend in the right direction. But cardiovascular death or hospitalization, huge benefits in patients with a reduced ejection fraction. There was one trial that looked at heart failure, not shown here, that with preserved ejection fraction that showed some benefit, and so it can be used there. In summary, for the SGLT2s, and I say plus or minus SGLT1s, really the most benefit is those with cardiovascular disease and or heart failure. In those that want to reduce hospitalization for heart failure, really all drugs showed that benefit. What we didn't see is a substantial change in stroke, although shown previously and in other ways, GLP-1s may actually have that benefit. So it depends on what you want to prevent as far as what you're going to be using. But if you want an improvement in cardiovascular death, EMPA and DAPA really have the most benefit to show for cardiovascular death. So those should be used preferentially, I would say, just based on the overwhelming data. In those patients with pre-existing heart failure, most of these with reduced ejection fraction, if you want to improve mortality and cardiovascular mortality, DAPA and CANA actually have shown most of the benefit. Some data to show that preserved ejection fraction may be beneficial, but most of the benefit is really in those with reduced ejection fraction. So with that, then we get to something like this. You say, here are all the choices, and I say, it almost makes your brain just explode. It's just too much. I don't know what to do with it. So to try to simplify it, it really comes down to whether or not they're drug naive or they're on metformin. This is more of a white paper really in European Heart Journal. But if they have cardiovascular disease or very high risk, then they should get an SGLT2 or GLP-1 that have benefit, and you can see some of the definitions of high risk versus very high risk. If not, then you can consider metformin for those that are more low or intermediate risk. Those that are already on metformin, again, low to intermediate risk, they could continue metformin, or in those patients that are high or very high, then we should be adding an SGLT2 or GLP-1. There's actually a guideline summary which expanded on this a little bit more, but really to put a capper on this, if the patients have atherosclerotic cardiovascular disease or stroke as a predominant problem, then suggest using a GLP-1 with proven cardiovascular benefit. If they have heart failure or if the CKD, which Dr. Nayan is going to talk about in a second, I would choose an SGLT1 with proven benefit. So with that, I'll go ahead and turn this over to Dr. Arora, who's going to tell us all about the nephrologist perspective on SGLT2 inhibitors.
SGLT2 inhibitors, this is basically like a beacon of light for us in the nephrology world, and I'm going to go through why. I think it's important to initially consider the philosophical approach that I have when I see patients. And my approach to diabetes may be different than yours, where what I'm really looking at is what's going to happen down the line, what's going to happen in that 10 to 15 year time frame. And I'm looking at how do I keep people off dialysis, because we know how much of a burden that is to patients, what the morbidity and mortality looks like, and how do I reduce cardiovascular events, because anyone with kidney disease, they're at increased risk for cardiovascular events, and that's always my first priority. Obviously you could put mortality in there as well, but if you're doing those top two things, that generally impacts mortality. And the things on the bottom that aren't highlighted, those are the kind of the short-term methods that we look at to see if we're achieving those goals. So glycemic control, blood pressure management, albuminuria reduction as a surrogate for kidney outcomes. And I'm going to highlight SGLT2 inhibitors as a tool within a lot of other medications that have come out more recently. But to see where we've come from, I want to give you a little bit of a history lesson. So in 1993, the CSG captopril trial was published. And this was the first trial to show any kind of intervention in kidney disease, particularly in patients with diabetes, to show long-term benefit. So this was in type 1 diabetics who were randomized to captopril versus placebo with a 3-year follow-up. primary outcome was doubling of creatinine, and there was a significant benefit. So 48% reduction in the primary outcome. There was also a benefit in terms of death, dialysis, and then a 50% reduction in the composite outcome if you received captopril. It didn't make it onto these slides, but I was going to show you the IDNT and renal trial because there was nothing for type 2 diabetes until 2001. So both those trials got published in the New England Journal looking at ARB therapy in patients with type 2 diabetes. And famously, it did show a reduction of anywhere from 23 to 28% risk reduction in terms of end-stage kidney disease, and famously no impact on mortality. And from 2001 on, we entered the dark ages, right? While Dr. Branch was over here in the cardiology world with puppies and rainbows and sunshine, we were sitting here with no options for our patients. There was a number of negative trials that came out and with no success. And in 2015, you get EMPA-REG. And this got everybody really excited, but we said, you know what, let's wait, because we were fooled by bardoxolone and some other medications that looked like they were beneficial, but could never be reproduced. But you saw this slide already. There was a robust kind of outpouring of studies, starting with Canvas in 2017, that confirmed those results. And every study after that has shown significant benefit, not only from cardiovascular outcomes like Dr. Branch mentioned, but also from kidney outcomes, giving us another option to treat our patients. This is a scatter plot looking at a meta-analysis of all the major studies so far, and this is looking at worsening kidney function defined as a creatinine increase or eGFR decrease by 40%, or end-stage kidney disease. And there is a just across-the-board benefit in hard kidney endpoints. But what's more exciting, or arguably more exciting, is there's also a mortality benefit. And this has been shown fairly consistently in every trial that's been done, is that patients are living longer when they're on these medications. And as I mentioned, if you compare these to ARB therapy, which was really what was studied over 20 years ago at this point, you have this similar effect on end-stage kidney disease, similar effect on heart failure hospitalization, but the big difference is that losartan, which was the first one studied, showed no improvement in all-cause mortality. But SGLT2 inhibitors do. What's interesting is if you go back in time and said if both of these drugs had come out at the same time, which one would we use preferentially? And if the answer may be SGLT2 inhibitors, understanding that all of the studies that have been done were on a background of RAS inhibition. This is maybe a hard slide to see, but what I wanted to show here is that it's important to know that these drugs work across a variety of eGFRs. This includes people with preserved eGFRs and people with lower eGFRs. And similarly, it works whether you are on RAS blockade or not. However, there's definitely added benefit if you're on both RAS blockers and SGLT2 inhibitors. And it works even in the absence of albuminuria. And why this is important is that there's 30 to 40% of people with diabetes and kidney disease don't have albuminuria. These are really driven by vascular lesions, more of a cardiovascular risk lesions. These drugs work even if you don't have albuminuria. What you need to know is probably obvious, is that the relative risk reduction is the same whether you have albuminuria or not. But of course, especially over a 2.6-year mean follow-up, the absolute risk reduction is going to be significantly greater if you have more albuminuria, just because those patients are at higher risk for more events. And Dr. Branch mentioned a little bit about mechanisms, and to be honest, we don't truly understand why exactly these drugs work. It's probably a lot of pleiotropic effects. That being said, I don't think it matters. I think we should be using these, and the mechanisms more important as we think about coming out with newer agents and alternative agents. One of the things that happens is this concept of tubuloglomerular feedback. So when you block your SGLT2 channels, you actually decrease sodium absorption, and that's the natriuresis that Dr. Branch was mentioning, which means you deliver more chloride to the macula densa, which causes a constriction of your afferent artery. So the artery leading to the kidney gets constricted, and you actually reduce renal blood flow. That's important for two reasons. Before I get into that, I know Dr. Branch mentioned that the kidneys are just there to accept blood for the heart, but you got to know that all the meds that have shown benefit in heart failure, every single one that has shown mortality benefit, with the exception of neprilysin inhibitors, works in the nephron, somewhere in the nephron. And SGLT2 inhibitors are no exception. They work in the proximal tubule. That's where your SGLT2 channels are located. And they actually change your kind of work of the kidney from creating cortical hypoxia to medullary. And that's what works on the hypoxia-inducible factor, causing the increased hematocrit and some of the other things that you see. And the reason this constriction of the afferent arteriole is important is because there's this whole, what I call the AKI myth, because I can't fathom how many times I see patients whose SGLT2 inhibitors are stopped because of a rise in creatinine or a decrease in GFR, and we're doing significant harm when we do that. So what we know, and this is from the DAPA-CKD trial, that being said, I could pull any SGLT2 inhibitor trial and show the exact same graph, where over the first year, you're going to have this increase in creatinine, decrease in GFR. That makes sense. You're constricting the afferent arteriole, you're reducing glomerular hyperfiltration, so you're filtering less, right? So creatinine goes up, but those curves cross over consistently at a year. And so what does that mean? We need to be tolerant of up to 30% increases in eGFR. It potentially is higher, but if that eGFR goes down by more than 30% after initiation, what am I doing? I'm making sure that there's not volume issues. The biggest issue that I see is people get volume depleted when they start these medications, particularly if they're on thiazides or loop diuretics. There's a very small risk of true AKI. And the way that happens is an osmotic nephropathy, where you get this vacuolization of your renal tubules because of the glycosuria. So it happens, it's been reported, there's a few case reports, but it's extraordinarily rare. The way that SGLT2 inhibitors work in tandem with ACEs and ARBs is that while ACEs and ARBs cause efferent dilation preferentially at the distal end of the nephron, SGLT2 inhibitors, like I mentioned, constrict the afferent arteriole. Combination of those two is decreasing glomerular pressure. So you get an immediate fall in GFR, but that leads to improved kidney outcomes. It's like a beta blocker for the kidney. You're doing less work and using up less ATP. As Dr. Branch mentioned, I counsel all my patients onto the risk of these meds. Just like any medication you're starting, you're going to have side effects. You counsel your patients, but some of these risks are overblown. So one of the things I hear a lot is this risk of urinary tract infections. I think one thing to remember is that patients with diabetes have a 60% greater risk of UTIs compared to the general population. So it's already a high-risk population. But if you compare SGLT2 inhibitors to other glycemic agents like DPP4 inhibitors or GLP-1 agonists, there is no difference between those agents in risk of UTI. So I actually don't think there's an increased risk of bacterial urinary tract infections with SGLT2 inhibitors. Mycotic infections, absolutely. So this is one of the bigger risks we see and something that I counsel all my patients on. There's about a 2 to 4-fold increased risk of mycotic infections. The good news is they're easily treated. And so generally one dose of 150 milligrams fluconazole kind of does the trick here. Very rarely, if ever, leads to permanent drug cessation. And the way I counsel my patients is general hygiene measures to reduce the risk. And then they know to call me immediately if they're having any symptoms of dysuria or inguinal rashes or anything that could go along with mycotic infections. Euglycemic diabetic ketoacidosis. So this is a concern. This was shown most prominently in things like the Credence and Declare trials. The earlier trials, I think before we recognized this risk, it hasn't really been shown much in a non-diabetic population. That's why you see things like DAPA-CKD at the bottom had no patients with euglycemic DKA. It also has to do with the fact that we recognize that pretty much every case of euglycemic DKA is triggered by something. And it's generally somebody who gets sick, they get septic, they have an adjustment in their insulin or other anti-glycemic drugs, or they're NPO for something. In the Credence trial, 83% of these cases were precipitated by some kind of illness. This is what I have if you use EPIC. This is a dot phrase that I put together in EPIC that just goes through sick rules. So having patients hold the medication if they're sick, if they're not able to take PO, to resume when they're feeling better. And to hold this medication, I actually do 72 hours prior to any scheduled surgery or NPO status as a way to decrease the risk. If you do use ertigliflozin, which happens to have a longer half-life, then you need to hold it for longer than that 72 hours. If you compare all the trials versus placebo in terms of risk, yes, there's risk of side effects, but they're pretty low. So hypoglycemia almost never happens. There's actually a higher risk in placebo in the DAPA-CKD trial. DKA, we talked about, extraordinarily rare. No signal for bacterial UTIs. We talked about mycotic infections, amputations and fractures. This is really not something that we've seen outside of the Canvas trial. So whether there's something with the SGLT1 inhibition, whether it was just happen chance, et cetera, we're not sure, but we haven't seen that with any of the other agents. So this is not a particular concern I generally have with my patients. More importantly, I think we just need to get the word out. And this is a slide actually showing RAS inhibition. So again, we've had these agents since 2001, and we do a poor job in this country prescribing these compared to other similar countries with people with diabetic kidney disease. And when it comes to SGLT2 inhibitors, only about 5% of patients with type 2 diabetes and chronic kidney disease are currently treated with SGLT2 inhibitors. There's a higher rate of prescriptions for NSAIDs and sulfonylureas than SGLT2 inhibitors. So this is something that I think needs to change. We showed you that mortality, end-stage kidney disease, all the outcomes we care about are improved with not as many side effects as I think people attribute. And just since we're talking about it, one thing to mention is that this is not, I know it's a diabetes echo presentation, but this is not just for diabetes. These drugs are effective in any form of chronic kidney disease. And so what I do is pretty much any patient with CKD and diabetes is eligible in my mind down to an EGFR of 20. So I use 20 because of the Emperor Reduced trial. EMPA Kidney went down to an EGFR of 20. That was stopped early for benefit. We won't have those results until November. And importantly, those drugs should be continued if they're started up until dialysis. That doesn't mean that they don't have benefit beyond that. It's just that it hasn't been studied. That's been my practice. In summary, well-tolerated drugs overall, but you still have to counsel patients. I have a dot phrase I print out for every patient I do this with, particularly think about volume depletion and when to hold it before any kind of procedure or if they're ill. Limited glycemic benefit, I don't think these are necessarily quote unquote diabetes drugs because you're not going to get significant impact on A1C, particularly at those lower levels of GFR. It shows improvement across the heart failure and particularly with those with reduced ejection fraction and CKD. I think the exciting thing is this reduced all-cause mortality consistently. So hopefully that 5% prescriptions goes up substantially.
Thank you very much, Nayan, for that great talk, and also for you, Kelley, for that great talk. I'm going to start with the cardiologist. My first question is, with the dapagliflozin study, Kelley, have you started to use the SGLT2 inhibitors in those without diabetes? And how commonly are you adding to those with reduced ejection fraction and heart failure without diabetes?
Yeah, it's a great question. It's one of those challenges in that there are so many medications to give people with reduced ejection fraction. It's the beta blocker, it's the ACE-ARB, then it's the MRA, so spironolactone. Now we have finerenone. We have all of these medications that we're layering on, and Entresto, so now we have sacubitril with all of these layerings that go on. So it depends on what's going on. It's mostly been patients living with diabetes that we preferentially give. We know that there's some benefit, and we know that people that otherwise have been having recurrent hospitalizations for heart failure, then we will try something else. Yes, they'll already be on torsemide, and now we try SGLT2, but it's just not as common, and there's just pharmacologic fatigue for a lot of these patients.
Great point there. Nayan, can you clarify how long you think the new recommendations are for holding the SGLT2 inhibitors? I believe your slide said 48 hours, but I believe the recommendation has been addended to 72 hours.
That's right. So that was an unfortunately old dot phrase where it was 48 hours. We've recognized now that the risk is actually longer than that. So I do 72 hours. Some people argue for even longer because there have been case reports of people developing euglycemic decay despite a 72-hour hold. But I think 72 hours is the correct amount here. And I just wanted to address a couple of the questions, if that's okay. Somebody asked about prescribing CKD patients independent of DM status. Absolutely. So DAPA-CKD showed significant benefit in CKD irregardless of diabetes. So that was a huge trial. It was actually, we joke about it, but it was the biggest IgA nephropathy trial that we have outside of testing, regardless of cause. Now, it's important to know that lupus nephritis and ANCA vasculitis and adult polycystic kidney disease were excluded from those. So I don't use it in those patients. Any other patient with CKD, particularly with albuminuria, I'm using that for. And then there was a question about GLP-1 agonists. There's other people that are more enthusiastic about GLP agonists in terms of renal benefit than I am. And the reason I say that is the only studies that we have so far have shown a decrease in new onset macroalbuminuria with GLP agonists. This could change. There's a number of studies ongoing, but we don't have similar outcomes to SGLT2 inhibitors. So we don't have the end-stage kidney disease outcomes. We don't have the mortality outcomes like SGLT2 inhibitors. We do have this decreased stroke risk. So there are those patients that maybe they have no albuminuria, they have significant atherosclerotic disease. And if you're trying to prevent stroke, GLP-1 agonists are probably your preferred. Any other cause of kidney disease, particularly with albuminuria right now, I'm preferentially using SGLT2 inhibitors.
Great points there. And I think the other thing Nayan did very well is I think we saw the benefits, right? We see the heart failure and overall cardiac and overall mortality benefits and the renal benefits in those progressing to end-stage renal disease, which is amazing data. But then you saw his side effect profile. I think that's a limitation that we find in prescribing the SGLT2 inhibitors is the time, right? And so my quick and dirty for how to talk to people about it, and especially as primary cares where you have even less time than we do, really good for the heart, really good for the kidneys. The side effect profile, everyone is at risk for urinary tract infections, especially with diabetes. You may have a slight increased risk. As men, you have a less risk because of your anatomy. Very rarely increased risk for yeast infections, and then very serious, but very rare would be the risk of euglycemic diabetes ketoacidosis, which means your body gets acidotic and the blood sugars look normal because you're peeing out your sugar. But what happens is the insulin is protective against that acid building in your body. So that's why then we have the instructions to hold it during acute illness. If you don't feel well, if you're sick enough to stay at home from work, or especially if you're having like a diarrheal illness or COVID, go ahead and hold those medications and restart it. I have myself, just with those simple instructions, have never had a patient develop euglycemic DKA. I have seen it in my consults in the hospital. You saw that took about 15-30 seconds to do. And I think what happens a lot of the time, if we don't spend that time counseling patients, then they don't ever start the medication. Lorena, do you want to comment on that briefly?
Yes, it's rare. We don't see it very much. And I do counsel my patients on how to prevent that. So when they are fasting, to hold it, same thing. There is the stitch protocol, which is just to review with patients about holding the SGLT2 inhibitor. So stitches stands for hold the SGLT2 inhibitor and have some carbohydrates with insulin if you are fasting and nauseous. Of course, if you are able to eat, you're not supposed to be fasting for a procedure. But with extensive counseling, it is very rare. I rarely see it.
Great points there. And then Kelley, do you have any final thoughts about the sodium glucose co-transporters and where they are in primary care's toolkit for practice?
Yeah, we were talking about, do you put it in the water? It's not quite, but I really like to think about this as a wonderful heart failure drug first and foremost, right? This is for your patients that, especially if they have diabetes, you have a good excuse, then this is a great medication for them because you are affecting so many, both from a cardiorenal standpoint. So that's where you go. Once you get to secondary prevention, where we're really seeing most of the benefit, then it's working with the cardiologist. And to be honest with you, most cardiologists are uncomfortable starting these medications. I'm comfortable with it, but me and my colleagues are not, between GLP-1s and SGLT2s. So actually, you can be on the forefront for helping your cardiologist give cardiovascular benefit.
I think that's a great point because this is a medication that we're really hoping to see increase in the primary care provider arsenal and your comfort level with it because of the glycemic benefits, the slight weight benefit, as I mentioned, where usually no more than 2 to 4 pounds, up to 6 pounds. But I do tell people they did see some changes in the visceral fat, which is always nice to tell people, like you lose the belly fat. And then as well, the cardiovascular and renal indications. And then finally, Kelley had mentioned ergotuflosin or stiglatro. The only reason I know how to do that, that's on the preferred formulary where I used to work in DC, but again, they haven't gone forward with the prospective studies that have shown the cardiac and renal benefit. We do believe it's a class effect, so whatever is on formulary would be the preferred, but there is probably the most evidence between using EMPA and EPA. Would that be a correct statement, do you think, Kelley?
Yeah, absolutely.
Okay, so Jayla, please go ahead and start your case.
I had a 66-year-old female who's transferring care. She's a new patient. She has uncontrolled diabetes with many complications, but her most concerning complication at our first visit was delayed wound healing from a partial right foot amputation. She comes to me with current medications, including Lantus 20 units twice daily and liraglutide 1.2 milligrams twice daily. She is monitoring her blood sugar at least once per day. She does report that she's she's concerned about her blood sugars being too low. And so she gave me the June 1st and June 2nd readings, which are there, and felt like at 120 on June 1st, it was so low that she was going to pass out. We did talk about previous medications she's tried for the diabetes, including blood sugar monitoring with CGM, which she said she tried the Freestyle and the Dexcom. Both fell out. She could never get them both to work, is what she says. And then she's also tried metformin, stopped it because she broke out in hives, tried Jardiance, stopped it because she had swelling of the windpipe, also tried Ozempic, says she got so sick, had a red rash on the skin and swelling in her abdomen. At our first visit together, the only symptoms of diabetes she just talked about were the weight gain, and she says that's because of the right foot amputation. She's not very mobile, can't get around much, and she also reported diarrhea. She does, again, have many known complications of diabetes, including cardiovascular disease. She's had a stroke, she's had an MI, she has hyperglycemia, neuropathy, diffuse neuropathy, and retinopathy. And of course, she expressed concern that day that one of her family members mentioned that they were controlled. She's concerned that she had type 1 diabetes instead of type 2 diabetes. Again, her medical history is there. We talked about the retinopathy, neuropathy, stroke, CDA, the osteomyelitis recently that she's dealing with. She's on 2 antibiotics for that. Of course, we'll see that on her med list. She also has hyperlipidemia, rheumatoid arthritis involving multiple sites. Her medication list, she's got the rosuvastatin, liraglutide. Again, she came to me taking it twice daily. At the end of our visit, I wasn't so sure she could take it twice daily, so I said for now, just drop down to once. The glargine, augmentin, and doxy for the osteomyelitis, which she was recently hospitalized for, nystatin powder, and oxy, loperamide, naproxen, and prednisolone, a mixture drop for her eye issues. She's got quite a few allergies that are listed there. Some of them I was able to get an actual reaction to those medications. Others, she was not sure what the reaction was, but wanted to keep it on her med list. So Avandia, erythromycin, glipizide, tetracycline, metformin, Jardiance, and Ozempic. In terms of family history, mom, this is what she reported to me that day. Mom, breast cancer, dad, diabetes, and heart attack, and he died from that heart attack. Sister, colon cancer, maternal grandmother, breast cancer. And it looks like on dad's side, some CAD, and then paternal grandmother had diabetes. She's currently not working right now. That is a goal of treatment for hers, is to get back working. She is married and lives with her husband, who she is the primary caretaker for, who also is very sick. He has heart disease, so she is his primary caretaker. She's never used tobacco, never used alcohol, no drug use. Vital signs were decently okay that day. And the current labs are as follows. When we did the CMP that day, the glucose was fine. Her hemoglobin A1C was 11.3, and this came down. She had the hemoglobin A1C done at the other location in February, and it was 15.2 at that time. So she had come down since February. I did not get a microalbumin that day. She didn't have any in the history that I could find either. But of course, EPIC has its limitations. And we went ahead and ordered the GAD antibodies. Those were negative. In terms of the standards of care, she recently just had the last retinal exam. I think she just recently had one in the last month, if I'm recalling. She's seeing the ortho for her foot care, so we didn't do anything in terms of monofilament testing that day. We needed to do the depression screening. I didn't ask about last dental visit. And when I asked about diabetes self-management education, the only thing, she was pretty adamant about not having diabetes education right now, but did say she was currently reading a book for keto diet for diabetes. That day, in terms of social services pathway, I did refer her to our registered nurse on site to help set up the CGM and titrate the Lantus, just depending on what her morning fasting blood sugars were. Some of the barriers to her care include the delayed wound healing with complications including the osteomyelitis, again, which she was hospitalized for, and reports of many complications with various classes of medications that I would have loved to jump on and use right away. We didn't really break down the type of meals that she was eating at that visit. However, she does say starting in October 2021, she started watching her diet more. Prior to that, she was only eating once per day, because she was feeling too tired to eat. And when she was eating at that point, she was eating Swiss cheese and watermelon and would feel full. So she says she's watching her diet more. Again, we didn't really get to discuss and break that down anymore, but that's where we are.
Great presentation there. And I saw at the end, of course, she has little to no activity just because of the recent amputation. Does anyone have any clarifying question? Allison Ward, do you want to start off with a question, perhaps, our mental health expert?
One of my questions was, where did she have the amputation and what was the extent of her rehabilitation?
Where, meaning in terms of location, or what, can you clarify that question of where she had the amputation?
Yes, under what medical system and what was the extent of her rehab for it?
Yeah, I don't remember exactly what medical system. It was in Washington. I want to say it was potentially multi-care. And then what was the second question?
Extent of her rehabilitation, physical rehabilitation.
We didn't get to go into that very much. Sorry.
That's okay.
She has a pretty extensive history of microvascular and macrovascular complications. Was she tearful? How was she acting about this newer complication and everything? Or was there no, very flat affect, etc.?
Overall, she was actually very pleasant and very nice and very eager to get better, to help go back to work as well as take care of her husband, but also very hesitant because of prior, as she perceived them, failures with therapy, including like the CGM falling out, not being able to do that, including reactions to medications. But she was open to pretty much anything and everything we could offer.
Great. So we'll let Lorena go on to her case notes for this particular interesting case.
Okay, yes, this is a very interesting case. This is a 66-year-old female with a history of diabetes, many micro and macrovascular complications that include diabetic neuropathy, osteomyelitis, and partial right foot amputation with delayed wound healing, and a history of MI and cardiovascular event. This is my first question. Do we know when she had these events, the MI and the CVA?
Unfortunately, I don't.
Okay, that's okay. She also has diabetic retinopathy with macular edema. She has many comorbidities, including obesity, dyslipidemia, rheumatoid arthritis, colitis, age-related cataracts, and vulvovaginitis. So this is a very complicated case. And to complicate things further, she has many intolerances or allergies to multiple medications, including metformin, empagliflozin, and subcutaneous semaglutide. She has failed CGM trials. They fall off. They haven't worked. And she also has a family history of coronary artery disease. On that side, father and both paternal grandparents with cardiovascular disease, breast cancer in mother and grandmother, and a sister with colon cancer. These are the medications, just again to review, and the many allergies or intolerances that she had to many of the hypoglycemic agents. This is the physical exam. She is obese with a BMI of 38. Blood pressure is normal, heart rate 95. And these are the most recent lab. At the time when she had her labs, glucose was okay. Her A1C is 11.3, so it has decreased from 15, we just heard. Creatinine is 1.18. This is the lipid panel, so the LDL is still not great. HDL is 42, triglycerides are high. I imagine this was fasting lipid panel?
It was not a fasting lipid panel.
Non-fasting? Oh, okay. That's good to know. So other important points is that she's eating once a day. I'm not sure that she continues to do that. And she has symptoms of low blood sugars when glucose is normal. She has pseudo hypoglycemia, and that happens because she has been living with very high blood glucoses with an A1C of 15. So then she's not used to normal glucoses. Then the first question we always ask as endocrinologists is, does this person produce insulin? And you already wonder that and investigate it, but it's always a good exercise to ask. It was very reasonable to obtain GAD antibodies because she has a history of autoimmunity, so she has rheumatoid arthritis. I'm not sure what kind of colitis she had, whether this was an autoimmune colitis. Do we have more information about it?
Unfortunately, we don't.
Okay, so it might also be something that runs in families. I'm just wonder about that because the sister had colon cancer, some autoimmune colitis increased the risk of cancer. So that is very interesting. Another clue to think about an autoimmune diabetes is whether there's autoimmunity in the family, and of course, whether they had a DKA or if they were very symptomatic at diagnosis. Her BMI is 38 now. I don't think we know whether she was overweight or obese at diagnosis. Do we know that?
No.
We don't know. So I would be interested in knowing how long she has had diabetes, because if she has had diabetes for a long time, well, then she might be insulinopenic, even if this might be type 2, most likely. Then I would check a C-peptide when glucose is better. I wouldn't check it right now, because sometimes what happens is when glucoses are very high and patients are very glucotoxic, C-peptide might actually be low, and it might mislead us to think that the patient is not producing insulin, but the patient might. I would check a C-peptide when glucose is better control. This is a study that look at patients when we are not sure whether this is an autoimmune diabetes versus type 2 diabetes. These are some things that might help us determine what patients, in what patients is a good idea to obtain antibodies. And I already kind of reviewed some of that. So when the diagnosis of diabetes is less than 50, when they present with very acute symptoms, not necessarily DKA, but if they present with polyuria, polydipsia, weight loss, when the symptoms are very acute, when they are not obese, so when their BMI is less than 25, when they have a personal history of an autoimmune disease, and this patient has a rheumatoid arthritis, or a family history of autoimmune disease. So then in this study, they look at the characteristics. They look at patients with LADA and patients with type 2 diabetes, and they observe that the patients with LADA had these characteristics. They were younger, non-obese, and they have acute symptoms, autoimmunity in themselves or in families. I use that all the time to help me determine whether it's worth to check antibodies. Sometimes it's not very clear. So I show you 5 different variables to assess. And then we have 5 variables. So if the patients have 2 or more of these, it's worth obtaining antibodies because it has a 90% sensitivity and 71% specificity for identifying autoimmune diabetes. If there is only 1 or less, then the negative predictive value is 99%. So then this is worth remembering. I use it all the time. So her antibodies were negative. That was great that you look at that. Now, moving on to non-pharmacologic intervention, exploring mood for depression. This is a quite significant life-changing event. I want to ask Alison Ward, our psychologist, how would you counsel the patient, or what kind of things would you ask?
I think that the adjustment of process for patients with medical conditions and medical events depends on a number of factors: patient him or herself, the extent and quality of support that they have, type of medical event, how it occurred, the extent and quality of the treatment they've received, as well as the duration of time since the medical event. Because patients' reactions can range anywhere from struggling or being grief-stricken to being fearful to acceptance, having integrated the loss or resulting changes into a patient's daily life, or finding meaning or purpose from what's occurred, or they could be a blend of those 2 major aspects. And thinking not just about depression, but just overall adjustment. If I were meeting with someone, I'd begin a discussion by saying something to the effect of, I want to talk with you more about what's happened for this woman with your partial amputation. Imagine this has been a big change for you. And so I wish to know how you're handling all of this. How has this impacted you? What's changed for you? Then leave it up to the patient to guide the conversation, avoid interrupting the patient, avoid making judgment statements about where they're at in their adjustment or how they're feeling. I'd be validating and empathic. You want to convey that their reactions or their adjustment are expected and understandable. And if the person presents as being pleasant, as in the case of this woman, or if you ask the question, so how are you dealing with all of this? And the patient responds with, I'm okay, I'm hanging in there, without elaborating on that, I would definitely dig a bit further to elucidate what the patient's experience really is, to guide further conversation, to assist with treatment planning. because particularly with this woman, I imagine there being a number of changes for her over time with her medical conditions, and then also more recently with the partial amputation. So I would talk with her about what have been some of those changes and what's been most difficult for her.
Thank you, Allison. I probably cannot even imagine, but it must be pretty frustrating to have tried so many medications and interventions like the CGM and not getting good control. That must be really hard. I think showing a lot of empathy is very important. We always want to review the goals for lifestyles and assessing eating patterns, but for the sake of time, I'm going to move on. The recommendations. So she is on a total daily insulin of 40 units a day. So she's using Glargine 20 units twice a day. She is 103 kilos, so that's 0.38 units per kilogram a day. Her fasting glucoses are at gold, and that doesn't really match with her A1C. And that makes me think about whether she only had partial adherence to the insulin regimen, or it's just relatively recent that she started using her insulin more frequently. This is a study that looked at A1C and the contribution of fasting or postprandial plasma glucose. When hemoglobin A1C is higher than 10, is mainly actually fasting hyperglycemia that is contributing to that elevation of A1C. So then her fasting glucoses lately had been pretty good actually. And then when she had a serum glucose, it was also okay. This also is very helpful because then you can see, not her case, but when A1C is closer to goal, to where we want it, when it's less than 7.3 is mainly the postprandial hyperglycemia that is contributing to that elevation. Then it is always a good idea to assess insulin use. I do this all the time, like every visit with my patients. I always ask them to tell me their insulin doses because they might be doing something different than what I see in the medication list. So assessing insulin use in a non-judgmental way. So I usually ask how many times a day did you inject your insulin? How often did you forget your insulin? And I normalize that we tend to forget insulin. So it's okay. I mean, it happens. So one, them to give them the confidence to tell me how often that might be happening. I use statements such as sometimes when we are very busy or we might be stressed, we forget to give our insulin, or we give it later. How often does that ever happen to you? And then they might just then tell me, yeah, actually, I sometimes give it once a day, or I want to be sure that I know how much and how they are using their insulin. Failing the CGM trials, when we are going to do a trial of CGM, I usually tell them the CGM, they are so comfortable because it's true, I wore several of the CGMs. So they are so comfortable that we forget that we have them on. So then you might just remember that you have this little device there because you might then accidentally, when you put your shirt on or your bra, or then you might, there it goes. So then just remember that you have it on. When they tell me that they keep falling off, then I advise to put the sensor in the inside of the arm like this. And then that way it's a little more protected. They might be a little more successful at the CGM not falling off constantly. I also review the technique, how they are placing it. You can see here, like this is the CGM and there is the adhesive. So then when it is placed, I wait there, pushing a little longer. So then the adhesive is really like really there. So then it is harder for that to fall off. Review how they are placing it and make sure that they are doing it correctly. Sometimes when there's skin irritation, this didn't seem to be the case in this patient, but sometimes when that happens, then I tell them that they can try to put a little bit of fluticasone nasal spray for allergies, use a little bit on the skin before they place the CGM. It's usually the adhesive. That works really nice. They can also try when there is skin irritation to place a tegaderm film, this one that first, and then the CGM on top. So then that might help as well. Or if the problem is that the CGM is falling off, then they might put this tegaderm on top of the CGM. So those are some tips that I give my patients. There is also this, it's called Griff Grips. I actually haven't really used it very much. I think Nicole probably has used it more, but this is a sports tape that it was designed. It was created by a NASA engineer. His son had type 1 diabetes and they needed a solution to keep this technology attached while enjoying the outdoors and playing sports. That's another option. But again, I haven't really used it much, but that's.
Lorena, it's just one option. There's definitely a lot of different adhesions, but what I point out with this is the grip tape is like $25 for the whole roll, so you can use it. But if you buy the individual ones, they're much more expensive. So sometimes, especially when cost is an issue, to use the big roll of tape to help with the adhesion. I actually learned about this from our diabetes educators. I've been the most successful with this product, but there's a lot of different adhesives that you could recommend. And I love your idea of doing the steroid spray in the case of irritation. That's a great learning point as well.
This patient has established cardiovascular disease, and she has a strong family history of cardiovascular disease in 3 generations already. We don't know how old the dad was when he had an MI, or when dad and grandparents, when they were diagnosed with coronary artery disease, but that makes me think about familial component. She is on rosuvastatin 5 milligrams daily, and with her history of intolerances to medications, did she have any intolerance or side effects to any or a higher dose of a statin?
No, we didn't touch base in terms of the statin history.
Then in this patient, I would consider a more extensive lipid panel, so an ApoB or maybe an Lp(a) because of her family history. And again, I would get more information how old she was when she had an MI, when she had a CVA. If this has not been tried, I would increase the dose of the rosuvastatin. And this is a question for cardiologists here. What would you recommend?
I don't want to be too dogmatic about it, but it's almost malpractice to put somebody on rosuvastatin 5 milligrams with this degree of cardiovascular disease. Someone has had an MI and a stroke and significant peripheral arterial disease. This patient is at the highest cardiovascular risk of anybody I can come up with, short of actually having heart failure with reduced ejection fraction. So yeah, it should be 20 or 40, ideally 40, especially with this level of hypercholesterolemia. It's going to be easiest to add on ezetimibe because it's easy to get to. We need a fasting cholesterol panel to know whether or not we should be using Vasepta or icosapent, because there's actually very good data for Vasepta to use that. Fibrates I tend to avoid unless I really need it. Bempedoic acid is possible, but you only get about a 20% reduction unless you're using another combination drug with bempedoic acid and ezetimibe in it. I think it's called Nexlizet, I think is what it's called. Has that combination, that'll drop in another 38% or so. But in this case, rosuvastatin 40, think about getting ezetimibe because that's easy to get to. And then for somebody like this, actually a PCSK9 would actually be very beneficial, but very expensive.
I wanted to tell you a little bit more about bempedoic acid because I think this has not really been covered very much, right? I think you had heard about ezetimibe after increasing the rosuvastatin to 40, but in patients who have an intolerance to statins, this is a medication that was used. It is very well tolerated when it comes to muscle side effects. And this is an option that I agree, probably a PCSK9 would be the best option, but when cost is an issue, this is another option. We don't really have, this is relatively new medications, we don't really have cardiovascular outcomes, but it does reduce LDL cholesterol in combination with ezetimibe. And the other points about this patient that I thought were very interesting is that she has this colitis, and I would obtain more information about what kind of colitis she had, and I'm curious about the sister as well because she had colon cancer. But in someone who has colitis, or many gastrointestinal symptoms and many allergies to medications, it is a good idea to think about possibly a food allergy. Sometimes patients who have a food allergy, if that is identified, then we can avoid that. And then perhaps it wasn't an allergy or an intolerance to medications. If that's the case and a food allergy is identified and avoided, then that could mean that we could try other medications with cardiovascular benefits, and that will help this patient a lot. So that's something to consider and to screen for gluten allergy. Then the recommendations, what I would recommend this patient would be to reduce her glargine to 30 units a day in one single injection because she is having symptoms of hypoglycemia, and even if her blood sugars are not low, but she's having the symptoms and they are very uncomfortable. So I don't want her to then not use her insulin. Then I think we can definitely reduce her dose, and we could increase liraglutide. So she is tolerating this medication, so she can go up on the dose. I would titrate very slowly because, again, her history of intolerances. I would titrate by 1 click. Then I got to 1.2, right? Like, and then just every week, just increase by 1 more click until you get to the max dose of 1.8. She does need better control, based on her A1C. I would add prandial insulin with a meal. If she's only having 1 meal a day, then I would guide her. She could use 5 units with a small meal, 7 with a medium meal, and 9 with a big meal. I would try a CGM again, because then CGM will make her life less difficult. It is not very pleasant to be doing finger sticks, hurts, and it takes time, and it's not very convenient. And then we don't know what happens in between finger sticks. Then I would try help her overcome those challenges with CGM that she has had. We'll talk about some questions. Would you consider a retrial of SGLT2 inhibitors? We just learned how beneficial these medications are. Would you try a different one? I want to ask our experts, what would you think? What do you say?
Kelley, let's start with you. I know you had some comments in the chat about, since she's already had a primary event, and it's things like aspirin anticoagulation. So maybe comment about that first, and then comment about additional tools that you would use if she's intolerant to sodium glucose cotransporters outside of SGLT2 inhibitors.
Right. Yeah. My comment was that I can't believe that she's with this kind of history. And again, it's going to be very interesting to figure out what was the MI. Was it Q waves on an ECG, or actually a true MI with troponin leak, et cetera? What happened, and what happened with the CVA? Was it really a CVA? Was it a TIA or something more nondescript? But at any rate, I think that talking about antithrombotics, if she had heart failure, she's definitely going to be predisposed to heart failure with this, if MI was really in there, and with polyvascular disease. So I think SGLT2 is a good idea. I think it would be very nice. Entresto is possible. We know that we have good data now with patients with preserved ejection fraction now. It's, again, just another very expensive medication, and whether or not it's going to get covered with everything else that's going on might be a challenge. I'd probably use an SGLT2 first, just because of cardiovascular benefit, rather than more Entresto, a little bit more of a heart failure benefit. But Nayan, what do you think about the renal?
Yeah, so that right now we're assuming this patient has kidney disease based on the retinopathy. I'll assume this creatinine is abnormal for this patient. It would be helpful to have the albuminuria data, because I think that would tip my hand one way or another. It doesn't look like they're on a RAS inhibitor at all right now, so either an ACE or an ARB, and that might honestly be my first go-to, particularly just from a renal standpoint, if she has albuminuria. There's a SGLT2 inhibitors, again, like I said, always a good idea. There's a few things here that at least give me some concern. If she does have very poor PO intake, these non-healing ulcers, we saw that with Canva, that was an issue, not so much with the newer agents, the history of vulvovaginitis. She's just a setup for complication. I don't want to scare her off from that medicine in the future when it might be even more indicated. The question about finerenone, I'm not convinced yet on finerenone. And there's been 2 studies. So Fidelio and Figaro were the studies. Independently, they showed a decrease in albuminuria, but no improvement in heart outcomes like mortality and end-stage kidney disease. When you pooled them together, there was an improvement in end-stage kidney disease and maybe a signal towards mortality, but we don't know enough yet whether independently it has this great benefit, and it's very expensive. And spironolactone may be just as good, which is like pennies compared to what Kerendia is. So I'm not convinced. I think using a good old ACE or an ARB would be my first go-to here, again, in the context of albuminuria.
Nayan and I are both twitching because of the naproxen that's currently there. So trying to find another agent would be ideal.
And I think one thing that's going to be challenging is that there are so many options that may have renal, cardiovascular, glycemic benefits, but we're working with a patient who's had many side effect profile. I think everyone probably would be in agreement that choosing one thing to target and starting one thing at a time. So if there was an issue, it could be understood what the medication issue was. She did come to you with the symptoms of hypoglycemia, but it seemed like ready for change for her diabetes. So maybe because I'm a diabetologist, I might say, focus on getting her diabetes optimized. And then I have had success with people who've had sort of non-specific, but a lot of like allergy type skin reaction symptoms to just doing baby doses. I think mentally it helps people, even if it doesn't do anything, if they truly have an allergy response to it. So a lot of times, if I was going to do a retrial of the sodium glucose cotransporter inhibitor, I would start at half of the smallest dose just to make them confident in it. And I do sometimes think that helps overall. I agree that she does need more strengthenings from a cardiovascular and the renal aspect, but I think doing one thing at a time. And the next time we present her, what we might be asking is how do we minimize or combine her medications a little bit to make things easier. That's why I think it will work to go down to 1 shot of the basal insulin a day and potentially a shot if she needs it with the meal. So I completely agree with Lorena on that. And then this idea of slowly going up on the liraglutide so it doesn't increase the side effect profile, but maximizing it, because then maybe she can get down to 1 shot a day from 2, which is already a win. And then you can talk to her about increasing her statin. Again, it would be done slowly. I have a feeling that's why it was started slowly, because of her side effect profile, and then slowly getting up to that goal of at least 20, if not 40. And then if we need to, adding the alternative cholesterol medications. This will be a marathon rather than a sprint, but over time, you're really going to be able to help this person. It already seems like we've done a good job partnering with her. Lorena, any final thoughts about this patient before we end the session?
Yeah, I think in patients who have a lot of history of intolerances and haven't been successful at keeping medications because of that, I usually start by telling them all the benefits that they have, right? So then if I tell them these medications are not just good for your blood sugars, but they also are great for your heart and for your kidney. And actually, when I tell them about SGLT2 inhibitors, I tell them they are so good that now we are using these medications even in patients who do not have diabetes, because we want them to benefit. And then when I start by telling them all of that, then already I feel that helps them to be more willing to accept their medications.
That's a great point. But it really is talking to them and then following up with them. I recently had a case of someone who had a severe urinary tract infection, not on a sodium glucose cotransporter inhibitor, and it was isolated, but it raised a lot of fear in him about starting a sodium glucose cotransporter. We compromised and we started at a very small dose, and we're going to monitor his kidney function very closely and have a urinalysis available for him just in case he develops any symptoms so that we could catch something early. But he also is someone who has known congestive heart failure with a reduced EF. So he definitely was a person that I would want on this particular medication. Always great discussions. As usual, we've gone over. So we'll just say this ends session 6 of the Cardiometabolic Echo. Thanks, everyone. Bye.